I hope you guys having a good day. So it's my pleasure to introduce our next speaker, Dr. David Fitzgerald. He is a professor and the division director of the cardiovascular perfusion program at University of South Carolina. And he is the past president for AMSECT. Also, he was the committee chair there for safety. He's a great educator and teacher. He's going to speak to us about ECMO simulation in perfusion education.
Good afternoon. Thanks for sticking around. As always, I've been to this conference a few times, and I really do value the contributions of the planning committee for this conference, probably even more so this year than any other year, given the local devastation from Hurricane Ian, and having this conference here, and anything that we can do, albeit fairly small, to give back to the local community in terms of their restoration efforts. I was delighted to be invited to come back here today. I'm here actually to present, not heavy in research, but to present how ECMO simulation is performed at my institution, which is the MUSC College of Health Professions, for our perfusion education program. But I actually want to share with you the technologies that are available in the market for those groups that perform ECMO, have an ECMO team of specialists, RNs or RTs or perfusionists, and need to incorporate simulation into their their initial and ongoing competency, psychomotor and affective domain competencies. And so I'm happy to share that with you here. I have no financial disclosures with respect to any of these technologies. However, with having multiple kids in college, I'm looking for some. So I'm actually going to show you my GoFundMe page at the end of my talk here. But I do have a personal bias, of course, working for a perfusion education program. And so in the interest of time and making sure I leave some for questions at the end, I really only have two learning objectives. And one of them is just to share my journey as a perfusion program director over the last several years, and keeping students, educating them in ECMO and keeping them proficient at least a year after they graduate from our university. And then secondly, to talk about the various techniques available that can be incorporated into any program, not a perfusion education program, but any ECMO facility. And I don't need to bore you with data to show that ECMO has had an enormous impact on our profession since 2010. And you can see an exponential rise in the number of ECMOs performed, both respiratory and cardiac, in adults and pediatrics, but then the number of centers that are involved in ECMO. And I'm sure most of you in the audience have been asked to be involved in some capacity in your ECMO program, whether or not you're sitting at the bedside or helping with initiation and discontinuation, troubleshooting, or even putting a patient on and then transporting them to a facility in which would be able to manage them longer term. And so we're seeing all types of modalities. ECMO over the last decades become, the shiny new hammer, and everything looks like a nail. So Bruce did a really nice job of kind of teeing this up for me. So I'm going to dovetail off of some of the material that he shared with you just a little while ago. What I'm sharing with you now is survey data that comes from the ABCP. And so every year when you recertify, you're asked a series of survey questions, and they usually relate to particular elements of perfusion practice, whether it's staffing, whether it's your involvement with ECMO, whether it's when you intend to retire. And this one was taken from the 2020-2021 survey. And I know it's a little blurry for you to see, so this might be a little bit of eye candy. But if you look here, ECMO initiation, about 79% of respondents had indicated that that's part of their responsibilities, at least over the course of that reporting year. And this survey had about 2,700 respondents, so really good response rate in terms of our profession. And even if I were to go down to ECMO shift work, over 2/3 of the respondents had indicated that they also are responsible for sitting some of the bedside shifts. So ECMO is firmly a part of our practice, at least at over 2/3 of all programs where perfusionists recertify. And because of that, we have a responsibility as perfusion educators to make sure that our students are graduating with that level of experience, so that way they can contribute fairly quick to a perfusion department's ECMO service. And I'm going to share with you a little bit, show you a little bit of my underwear here with MUSC and the things that we've done over the last several years in terms of making sure we're meeting the need for the community. And so every perfusion education program should have an advisory committee, and that the advisory committee consists of the program director, the faculty. There's usually someone from an administrative capacity. At our institution, we have our department chair as well as our associate dean of faculty affairs. We have representatives from our clinical practice, from an employment practice, from alumni, from current students, and so pretty robust advisory group. And every year we look at our outcome data and find the areas in which we're performing well and identify those, but also find the areas that we believe that we can improve on. And we collect lots of data from when they're a student, all of the evaluations they receive on clinical rotations, and then when they graduate, approximately 6 months to a year after they graduate, we send them surveys. Surveys of the graduate and whether or not they feel now working into the market for a year, do they feel like they've had a good education experience? And then we also send them to their employers and ask their employers, you know, do you feel like this person that you hired as a graduate of our program, you know, was qualified and capable and, you know, had the skills necessary to succeed in your program? So we take all of this data, we report it every year, it becomes part of our annual report to the ACPE. And every year, what we've noticed over the last several years is, this is real wood, knock on wood, our scores have been very good, and our students and graduates and employers have been happy. But the one area that people comment on is, yeah, things are great, but you can do more ECMO. We need to have more ECMO involved with our graduates. And so you can see what I'm sharing with you here is a series of PDSA cycles. So we look at this as quality improvement opportunities. So some of the things that we did was with regard to ECMO back in 2016, 2017, we created a standalone ECMO course, a 13-week standalone ECMO course. Now they get ECMO in other areas of their curriculum, but this is a standalone 13-week course on everything related to ECMO. And then, you know, they said, yeah, that's great, but we still need more. And then we went to, okay, let's go ahead and increase the number of rotations on MUSC campus that they're actually observing and participating in ECMO. So we went from one semester to 2 semesters. We incorporated them rounding with the team every day, being there when there was transition of care or oxygenator changeouts, taking call for ECMO. We were strategic in the rotations that we set for them to ensure that while they're out on external rotations, they'll be able to experience clinical ECMO procedures, increase the hands-on experiences while they're on campus with simulation, with some team training, and improve the fidelity of the ECMO simulation that we're incorporating. And so every year we think that we got it, and you know, yeah, that's great, but you can use a little bit more. So this has kind of been our journey over the last several years. And as I said, we do the employer evaluations and the graduate evaluations, and they're all on a scale, a Likert scale up to 5. And for us, the metric is that at least 80% of these scores should be 3 or higher. We've changed it over years, so we're looking for scores of 4 or 5. 80% of those scores 4 or 5, and then we also look at the mean. And a mean for us of 4.6 or higher would be excellent. So the ECMO one is near 4.6, but you can see for the employer survey here towards the bottom, it's about 4.25. So we think that we could increase increase the experience, continue to increase the experience for students. And we look at it from the cognitive domain, their clinical knowledge, their psychomotor domain on their hands-on skills and abilities, and then their affective domain. Their affective domain being, can they synthesize the information, make valuable judgments, kind of the higher level appraisal of advanced troubleshooting for ECMO. And Bruce showed this Unit 3 as part of the ACPE curriculum, so I've kind of exploded it here. And you can see all the areas that perfusion education programs are responsible for providing to students. And as he alluded to before, if we don't, we're held accountable for it. And eventually, if we continue not to adhere to the standards, we'll no longer be able to take students. And so these are all the areas in which we can point to the curriculum to say, okay, this is where we go over complications. This is where we go over the disadvantages of ECMO. If you were to look at the ELSO training outline, you can see here lots of different topics. I think Bruce described it, and I agree, quite not as robust as we see through the ACPE. But again, if you're a center that performs ECMO, I'm willing to bet that if your center is a participant in ELSO, that this is probably the structure that you follow in some capacity. And it's not just for the clinical knowledge, that 24 to 36 hours, it's hands-on training and competencies, and then lastly, continuing education for specialists. So bringing that all back and synthesizing that, we said, okay, how can we make the ECMO learning experience more enhanced for students? And so what I'm going to show you of some of these tools can be incorporated in any perfusion or ECMO education program. These are the things that we found helpful at our program, but nonetheless, they can be involved in any hospital-based critical care team. And so the first one I'm showing you is from Harvey. Harvey is an online simulator system. And what we're doing here is I'm taking a recording here of a class, and you can see this is an LV pressure volume loop. And what the instructor just did here is put this patient in acute heart failure. So now what you can see is the LV pressure volume loop kind of shifted to the right. You can see heart rate's gone up quite a bit because the circle is kind of moving fairly quickly. And you can see as they're walking through the decision tree, what the available therapies they can incorporate. They can incorporate inotropes. They can try putting in a balloon pump. Here you can see they went with peripheral ECMO support. And one of the interesting things that you're noticing is that the LV pressure volume loop is still shifting to the right, meaning that we're not unloading this ventricle here. You can see the aortic pressure is still fairly high, so they're starting some vasodilator, try to offload the ventricle a little bit. Eventually, you'll see here they'll go through a decision tree, maybe try to offload the ventricle by incorporating a balloon pump. Yeah, that really doesn't seem to be doing too much. Eventually, you'll see they'll come to the decision of putting in an Impella pump and putting this patient on ECPella to drain the LV. And so part of our simulation experience incorporates some of the initial patient presentation, what their hemodynamics say, what would be the best therapy for this patient. This patient's in shock. Is ECMO the right solution? Should we go to a transvalvular pump like Impella first? And so allows the learner to have more decision-making in the process and, through trial and error, figure out that maybe this isn't the best technology for them. When it comes to cannulation, so now you've pulled the trigger, we're going to put this patient on ECMO. A lot of neat, there's a number of groups that are out there. This one is from David Palmer and his colleagues out at Pittsburgh Children's Hospital in Pennsylvania. They've incorporated a lot of homemade cannulation models. And so, and we've done this at MUSC over the last couple years where we've purchased ballistics gel. There's a company in Greenville, South Carolina that will sell it to us. And we actually put it into a crock pot, melted in the crock pot. My wife's still pissed at me. I used her crock pot for one of these and ruined it. And so I had to buy a new crock pot for the family. But nonetheless, we've purchased these dress models on Amazon and cut them in half and bore some holes with some silastic tubing. And we're able to incorporate, cannulation models that actually could be used with ultrasound. And now the students, along with some of our intensivists, can actually train together on putting patients on ECMO support, whether it's groin cannulation or neck right IJ cannulation. David's actually taking it a step further. These are some of his cannulation models where you can see the fidelity is improved. This Wheatlander here is exposing the cut down, and you can see, some of the femoral vessels that are here. He's taken this the plies out of the rope, hardened it, and the durometer and the diameter of these ropes are actually similar to the femoral vessels. And so now you can do a more realistic cannulation with a skin model. And the ends of these, we've put connectors on them and incorporated into our calyphia. So now you can put patients on simulated ECMO with some conventional homemade items and still have that experience. If you have the money, we had a bake sale out front of the hospital one time and was able to incorporate this new technology, which is from the simulation company. This is called the ECMO Pro. And so this is a full peripheral cannulation model. We're going to be incorporating it into our program this summer. This one is kind of a step further that, yes, it does communicate with the calyphia, but it's a simulator all by itself. And not only will it, you can change the parameters in terms of the drainage or the recirculation factor, but the nice thing is that you can actually incorporate other therapies. And so if they wanted to put in an Impella pump or a balloon pump, you can do that in tandem with ECMO cannulation. So we're very much looking forward to incorporating that into our curriculum this summer. And again, most of you appreciate the fact that you don't have to have high fidelity technology to do some of these things. This was a paper out of the University of Nebraska Medical Center where perfusion students were able to demonstrate with low fidelity simulation, just a closed soft shell bag, that they were still able to incorporate some crisis management drills and emergency drills on ECMO. And they found that they've concluded that in the population of students that they've enrolled for this, that it's helped strengthen their skills in rapid management deployment of ECMO, helped reduce errors, and then lastly, had higher confidence on some of those crisis drills. So these are some of those wet drills that we talk about with low fidelity simulation. I'm sharing with you here, this is the calyphia simulator here, and I think the group out of Nashville at Vanderbilt were some of the first ones to incorporate this. I'm going to go ahead and play this video. They've actually taken porcine hearts and lungs and incorporate them into the simulator and have them beating. So the calyphia simulator has a beating heart model where you could actually simulate central cannulation. They've done some of this, not just for ECMO, but for bypass, and it's become part of some of the curriculum that the STS has had over the last few years with boot camps and some conference simulation. And so we've tried this once. We made a mess. Hoping to try it again, but still pulling chunks of pig heart out of our simulator. But it does work, and when you work with surgical residents, the ones that are having to either cannulate these patients centrally or transition from central cannulation of bypass over to ECMO, some of these things, have value in terms of their ability to do this. And then, of course, being a perfusion education program, most of the schools now have high fidelity simulation. And I'm just going to share this loop with you just for a moment. But in our high fidelity simulation lab, yes, this is a bypass pump, but we can bring in our students and test them out on these fundamental skills of bypass and then for ECMO. And, because we have the luxury of having this technology at our facility, you can see the split screen where we can show students, and I'm going to defy logic here and speed up physics. You can see the students getting ready to go on support here, and just a moment she'll stop and her heart will drop because she'll realize I just failed her oxygenator. But so these are the high fidelity experiences that students have while they're in the program, again, incorporating it for bypass and then for ECMO. But we ran into, a little bit of a conundrum during COVID, in which because we actually had to close our campus for several weeks with the onset of COVID, we fell behind a little bit in our simulation schedule. In fact, we were about 7 weeks behind by the time we were able to bring students back on campus in small group gatherings. And so our curriculum has 2 semesters of simulation, the summer semester being more case-based. And so students will have about 13 weeks of case-based simulation before they go out to their first external clinical rotation. What we found was that by missing the first several weeks of the semester, we had a lot of catching up to do. We didn't want students to leave Charleston without, having the same level and skill that our previous students had. And so we actually broke into another lab room and had 2 simulator rooms running. It was only my colleague, Laura Delaire, and I that were doing a simulation. And so we had 2 rooms running parallel, but the other room didn't have the AV capabilities of recording these simulations and testing them out. So we actually made a homemade model that we're going to be showing as a technique paper here soon, where we've incorporated Zoom and put some iPads and laptops with webcams sparse through the room, had them all log into Zoom and ran simulation through Zoom. So here's the instructor here, here's the learner. We had Zoom cameras, 4 different cameras set up, and we were able to do the same thing that you had just seen in that split picture, for pennies on the dollar. Everyone has access to Zoom. Yeah, we had to hijack an iPad or 2 and use our proper laptops, but we were able to record those videos, make them available to students, actually annotate on them. And so we were able to make the best of a global pandemic. As my dean once said, don't let a global pandemic go to waste. What can you learn from this experience? And then, of course, team training for simulation. Again, we'll be incorporating eSIM Pro and working with our intensivists and our residents this summer. But there's also online 3-dimensional simulator programs that are commercially available to everyone. Again, this is Harvey Online, where you could actually see incorporating patients on ECMO support. You can see the cardio help screen that's here, make adjustments to the settings and flow. You can see all the physiologic parameters. One of the licenses for this, I think, is 50 or 60 bucks. I mean, I probably spend more in Starbucks coffee a week than what I would pay for a year license here. So, and we bring this actually into the classroom. So we may have a classroom full of students and we'll actually walk through a simulation, incorporated as a fundamental part of the class. This is one from Biomed Simulation. This is their 3D ECMO simulator. And I'll let this run for a moment. And we too have used this in the classroom. You can see we have a patient that needs ECMO. We're going to go ahead and employ our cerebral oximeters. There's a little bit of a gap or a delay in the way that the picture's moving. That's actually my fault. That's actually a recording of a video loop. And so it's running a little bit slow here for you guys. But you can see, you can have the student, the learner, go through this process just like we would if we were getting ready to work up a patient for ECMO support. Make some adjustments to the ventilator. And if I were to speed this up just a little bit here, you can see that we're getting ready for ECMO support. Go ahead and turn your blender on. Go ahead and ramp up your RPMs. We'll take the clamp off the line, and away we go. We light this firecracker. Now the patient's on ECMO support. So this type of technology we really see a lot of value in as well, not only in a classroom setting, but we can actually do this remotely. So the learners don't actually have to be in Charleston to do this. And we did look at this as a quality improvement opportunity. In fact, that was one of the last PDSA cycles you've seen in the beginning of the slide set. And we did submit this for peer review. We just got word back earlier this week. It's accepted. So you'll hopefully see this in a journal in the not too distant future. But we incorporated class-based 3D simulation in our program. And the students overall, this is what's called the user experience questionnaire. It's a validated taxonomy on evaluating interactive online programs. And the students, the 26 students that participated in this, found all of the 26 categories or 10 major domains found to be excellent or good. So they had a really good experience using this level of fidelity of simulation and virtual environment. And then I recall, you know, a great presentation that Jeff Riley gave a few years ago at the Academy meeting, showing how you can take the simulation technology and run it through a cloud-based system. So at the conference, he was actually showing how three of his students in the SUNY Upstate Perfusion program were actually able to participate through Teams, through Zoom, and actually walk through with an instructor a simulation that was done remotely. And gosh, in the height of COVID, that's a wonderful technology to have so the students don't skip a step. And then I think lastly, just to close and leave some time for questions, we're on the precipice of seeing virtual reality. So this was presented at the European Society of Intensive Care Medicine back in October, virtual reality ECMO simulation. And we actually have companies working on that with Bypass CPB right now. There's Viridex, I think, is the company. It's an online gaming system created by researchers in Barcelona, Spain, and they're close to launching an ECMO model that looks similar to this. And, you know, how far we've come in a short period of time in terms of having this wonderful technology available. So I'll close with just saying that, you know, I'm particularly excited about some of the technologies and tools that are out there to help enhance and supplement our education. You know, when I learned ECMO, you know, when I graduated school back in 96, you know, I was fortunate to see one or two ECMOs, but that was the extent of my education in school. And so what the tools that we have that perfusion programs and ECMO programs can provide, I think is really just exciting stuff. And so thank you so much for your time, and look forward to the discussion.